because we're going to be full. We've got for the next half an hour Matthew Gould, who's going to talk about his new job. I think, does NHSX start next week? Monday, there we are. So he's talking, this is probably a part of his extended interview then. He's talking before he takes the job up next Monday about what NHSX will do.
Thank you. So, like Paul said, I'm Matthew. As of next Monday, I will be the Chief Executive of NHSX, which I am calculating gives me about 90 hours to change my mind. If you've followed me on Twitter, you'll have seen, I've been going around the country, you will have seen a variety of slightly wobbly smartphone videos filmed all over the country at odd times of day and night. You'll be pleased to know I'm not actually running an insurgent campaign for the leadership of a Conservative party, but what I have been doing is a journey right across the health and care system. I've visited in the last month hospitals, GP surgeries, dentists, pharmacies, mental health clinics, psychiatric hospitals, care homes, hospices. I've visited some of the most digitally advanced bits of the system, and I've visited organizations which run almost entirely on paper and on the goodwill and brilliance and commitment of their staff. Today I want to talk about what I've seen, what I've learned on my travels, and what it means for the work of NHSX, this new organization that springs into life on Monday. But before I do that, I wanted to answer the prior question, which is, what is NHSX? And the answer is essentially this, that previously you had some brilliant, committed people across the system, but with the powers and the levers quite seriously disaggregated. So you had the Department of Health, Social Care had some of the powers, NHS England had some, NHSI had some, and so on. And the idea of NHSX is we should be a new single lead point for the NHS and for social care, combining teams from NHSE&I and DHSC, taking a situation where the powers and levers were fragmented, where as a consequence silos grew, where as a consequence these brilliant and committed people had to spend a lot of their time managing the institutions and managing each other, and try and get to a point where inside NHSX, working incredibly closely with NHS Digital, we will have the powers, the levers, the ability to make stuff happen, hopefully aggregated in a single place. That means pulling together DHSC's ability to set policy, to deal with Whitehall, to talk to ministers. It means pulling together NHS England's links to the entire system, NHS improvement spend controls, and digital expertise and knowledge and wisdom from across the NHS family and beyond. So we have one team, one decision-making point, one very clear mission, which is to give patients and staff the technology they need. But I know what many of you will be thinking, which is you've seen this movie before. The Big Bang announcement, the brand new organization, shiny new leader who comes in optimistically, the optimism before the fall. And there is some form to this. Whether it's the national program or care.data, I understand the level of skepticism that we're going to be operating in. And I want to address it head on. I want to talk about why this time may be different and ways it won't be different, and what we've learnt from what's gone before. And one thing I want to make absolutely clear is I don't believe we're starting everything completely from scratch. I don't believe that everything that went before is worthless. In fact, quite the opposite. I know I inherit a brilliant team with some superb programs in flight, where a lot of fantastic work has been done and some fantastic thinking, and it is by no means the case that we're starting again from scratch. I have no intention, I'm far too lazy, to try and stop everything, reinvent everything, and start again. So what is different? Well, one is we're not going to go for big bang projects. I'm not going to sit at the center and try and impose single solution systems on 240 different hospital trusts or every CCG. And we know from what's happened since the national programme that the answer isn't simply to let 1,000 flowers bloom and let everyone in the system work out the answer for themselves. There needs to be a sensible balance, and this is something, to be fair, that I think people in the system have understood for some while and have been moving towards. So there needs to be freedoms for the system to work out its answers, but within parameters that ensure that different systems across the NHS can talk to each other, and that we learn the lessons that are being learned right across the system, and those lessons are shared. So it's not so much let 1,000 flowers bloom as 1,000 standardized flowers. Actually, I should say I've been told off for using that phrase by Hadley, the Secretary of State's tech advisor, who says it's not the flowers that are standardized, it's their roots. So it's 1,000 flowers with standardized roots. And that essentially means our approach, our focus, is going to be on standards. In plain English, it means the most important thing we do will be to set rules so that our systems can talk to each other, both technically and semantically, so that our systems are secure, keep patient data safe, and then within those rules that allow those things to happen, ensure those things happen, we'll let local NHS organisations buy or build whatever they want. Because it's been very clear to me as I've travelled around the system, you know the needs of your staff and patients far better than we can at the centre. So you should control the technology you use. The last thing I want is to sit in Skipton House and tell you to a minute level of detail what all the answers are. And if we get this right, if we can have standards that ensure systems speak to each other, then there shouldn't be a need for a single giant NHS patient database, because we'll instead have created a single federated data layer. In English, all the different databases will be able to talk to each other. So, with appropriate permissions, you and your care teams will be able to see your primary care records, what's happened to you in each hospital you visited, and so on and so on. Second thing about how we're going to operate is this. We're not going to try and do everything ourselves. We're going to keep the centre thin. I am really allergic to central bloat, where NHSX gets bigger and bigger. My empire gets larger and larger. Instead, my goal is to keep the centre thin, to have what we need at the centre to do the tasks I've described, but instead to focus on creating the platforms on top of which other people can innovate. People from inside the system and people outside. Now, what does that mean in practice? There are some things that it makes sense to do centrally. There are some functions where very clearly, essentially the same thing is being done in all sorts of different bits of a system, and it doesn't make sense for that function to be bought or built or procured over and over again. So for things like screening or booking, I think there will still be a role for the centre, led by NHSX, to procure or build those central functions. But I don't want us to do too much, and perhaps the best way to explain this is through an example, which is the approach to the NHS app. I think some absolutely brilliant work has been done on the app by the team in NHSX, the team in NHS Digital, Keynote, who are the contractors. I think they've done a superb job. The percent of GPs who are now GP surgeries that are signed up to it is really extraordinary. And I think the app can really change things. But I don't want to load it up with more and more functionality. What I'd like to do instead is actually hold it, plus or minus where it is, expose the APIs, the data pipes that lead into it, so that with appropriate permissions and consent, others can use them, and then let other people innovate on top of it. And that, for me, allows something quite extraordinary to happen, which is not everything that happens in technology. Every piece of innovation has to be dreamt up and thought of and paid for from the center, but rather the center can provide a platform for innovation, and then there will be people out there, doctors, technologists, managers in hospitals, who can see the need, who can see the opportunities, who can innovate in ways that I won't even dream of, and be able to do so using the platform that we create. So instead of suffocating that innovation or crowding it out or not letting it in, we create a platform for it. So for example, very recently I met a brilliant doctor who had developed her own algorithm to assess the risk of a patient not showing up at a clinic. That was a brilliant piece of innovation from within the system. I want innovators like her to be able to have a platform for that innovation, and for the NHS to be able to make best use of that innovation. So that app developers or clinicians or whoever who have ideas, who have expertise, can innovate in ways that we at the centre can't even dream about. And then there's a third thing we're going to do, which is have a relentless focus on local capability across the system. And this is something which I've seen really vividly in my travels around the country. There's frankly no point my sitting at the centre or coming to conferences like this and giving nice speeches about interoperability and all the brilliant things that can be done with technology if at the same time you're still having, as in hospitals that I've visited in the past month, triage nurses in A&E write everything on small bits of paper which then get taken over to the other side of A&E, and the whole thing runs according to little bits of paper shuffled around the system. That can't work. So we need to make sure that the system and all its component parts have the capability, technological and human, to be able to do the things that we're talking about. And that means the skills, it means us investing in skills, investing in equipment, yes, it even means the money that they need to transform. So that's our approach. Incremental improvement, not grand digital projects. A relentless focus on standards and platforms, and focusing and trying to divert resource to the front line where better tech can make the biggest difference. And I want to say one other thing before I come on to some of the things I've learned in my travels around the country, which is I'm very clear that our mission isn't just about health, that our mission extends to social care as well, and I'm really keen that social care shouldn't be the afterthought that we get to at the end of each meeting when we've done discussing the NHS and health. The opportunities for digital technology, standards, interoperability, and some of the things we've been talking about in the social care system are absolutely enormous. And frankly, the levels of digitization in the sector are at some of their most mixed of all the places I've been. I've been to care homes. I've sat down with care providers, social workers, care workers. I've seen the commitment they have to looking after the people they care for, and the opportunity that exists if we can get tech right for social care as well as the NHS. So what did I learn going around the NHS? Firstly, and it bears saying, it won't be a surprise to you, but nonetheless I want to say it, the staff blew me away. I was genuinely moved by the doctors and nurses and pharmacists and dentists, the managers, the social workers, the physios. All the different people I've met had a shared, profound concern for their patients and the people they were caring for, a concern for patient safety. They wanted to do their best for their patients. And I saw a lot of brilliant things in digital technology as well. I don't want to say what I saw was a barren wasteland. Far from it. I saw Chase Farm, for example, which has just got its NHS X accreditation. A brilliant example of what can happen when a hospital really is determined to invest in technology. I was up yesterday, I'm losing track of the days, in Newcastle, where I saw the Great North Care Record, which just shows what can happen when brilliant people, brilliant committed people get together and are determined to make something happen across a complex system. I saw an AI system called HeartFlow when I was at Watford General, which was a superb use of AI in practice, where the clinicians were bursting with pride about how they were using it and what it was doing for their patients. But I also saw, pretty much everywhere I went, the impact of systems that couldn't speak to each other. It will always stay with me, the conversation I had at a hospice in Salford, where the physios told me that they couldn't access the notes from their counterparts in the acute trusts, so that they were starting to take care of and look after dying patients, and they didn't know the movements that the physios in the hospitals had been working on. And they were acutely conscious that this was impacting their care for this most extraordinarily vulnerable group of people. I thought that was desperately sad. In the same hospice, the doctors were telling me about the hours they have to spend on the phone waiting for blood test results, and how easy it is when you're ringing up and reading out long numbers and getting long numbers back for mistakes to be made. I saw a mental health team, a brilliant mental health team, who told me about they were going to see a patient and were worried about medicine she had. They weren't sure she was able to use the medicine safely, so they took the medicine away from her, unaware that that medicine had been given to her by another team which had been visited her earlier in the day. Or a woman who was wheeled into the resus unit I was in, clutching in her hand the discharge notes from her previous stay in hospital, which was frankly fantastically lucky, because given that what she was presenting with, if her doctors hadn't been able to look at the notes and see what the cause of it was, they would have treated her differently. Interoperability sounds like it's about tech, it's all technical. NHSX sounds like it's frankly about technical stuff. But when I think of it, I think about the physios at the hospice in Salford trying to provide the best possible care to a dying patient and being hindered in doing so because they couldn't access the systems that told them what the physios in the hospital had done. And I am really conscious. The NHS isn't actually about tech. It's about the patients, it's about the staff trying to help them. And what was really obvious to me was right across the system, every day, all over the system, there are staff spending slices of their time doing workarounds, calling each other up, chasing for blood test results, trying to find patient histories, doing the best they can without those patient histories. And if we can make progress on interoperability, if we can save all those slices, then it would add up to an awful lot of time that staff could then spend with their patients. And the impact on patient safety and outcomes would be real. And I'm also conscious it isn't just about interoperability. As I went round, the single biggest complaint that I had over and over was about login times. People telling me it took 15, 20, 30 minutes for them to log into their computers. I saw this vividly in one care team I was in, where the nurse wanted to show me the system she used. And she logged on, and we waited, and we waited. And then just as she finally got into the system, I had to run for my train. So I never actually saw what it was that she wanted to show me, but I did see how long it took her to log on. And I've spoken to staff across the system working around systems that don't talk to each other, staff coping with slow kit. I met yesterday, actually, in Milton Keynes, a mental health consultant who was still furious that she had spent 45 minutes typing up notes on a system which didn't have an autosave, and then just before she finished, the system crashed. And I've been quite public about this. We live it in my family. My wife has had breast cancer, and she has to travel around all her appointments with the bundle of papers so that each of the specialists she sees can see the record of her previous tests, her scans, her care, because if she didn't, they would be navigating blind. So what does all this mean for our work, for the work of NHSX? I have set 5 missions for what we do, very intentionally framing it in terms of real-world outcomes that I want us to deliver on. They are to reduce the burden on clinicians and staff so they can focus on patients, to give citizens the tools they need so they can access services and information directly, to ensure that clinicians can access information safely from across the system where it's needed, to aid the improvement of patient safety, and to help improve productivity using digital technology. And I've framed these in terms of missions because I want us to lift our eyes above the minutiae of programs and projects and focus on what all this is essentially for, which is to make life better for patients and staff. It's how we're going to define success at NHSX. But I'm determined as well, we shouldn't pretend we're inventing this from scratch, we shouldn't overpromise. So let me be clear. I am very lucky to inherit a team, a set of programs, a load of thinking, which brilliant work has been done. I think the LICRA program, for example, is a really well-conceived, important program, which I'm pleased to carry on supporting. I think some of the local initiatives I've seen, I talked about the Great North Care Record, for example, are absolutely superb. In my month going across the system, I have seen extraordinary providers, innovators, adopters. And I have no expectation that any of this is going to be quick or easy. I'm very nervous about overpromising. A lot of what we do is necessarily not actually going to be about the tech, but about what you might call the softer stuff. The trust between local partners, the confidence people have across the system in information governance rules, the willingness of boards to question and support and invest. All of this, trust, links between people, confidence, takes time to build. We have a huge opportunity here. If we get it right, I'm absolutely sure we can make life better for the millions of people who rely on the NHS and the social care system. We can remove an element of grind from the jobs of doctors and nurses, clinicians and non-clinical staff across the system. We can save time for staff and patients. We can improve patient safety by making sure that all the teams working to help someone communicate with each other. We can give citizens tools so they can be partners in driving their own healthcare. More time to care, less time ringing up for blood tests and sitting in waiting rooms. That's what this is about. So now, the simple task we have is just getting on and delivering it. In that, you will all be our partners. So thank you in advance for your cooperation.